Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What is new with pain management? Find out more right now. My guest this evening is Dr. Ramani Peruvemba, a noted pain management specialist right here in Montgomery County. Ram, welcome to Housecall.
Thank you. Nice to be here. Thanks for having me.
Our pleasure. So briefly, Ram, tell our viewers about your professional background and training that led you to specialize in pain management.
So I I went to medical school in New York, and I trained in anesthesiology in New York City at Cornell, at New York Hospital. It was called New York Hospital then. Now it's called New York Presbyterian Hospital. They merged with Columbia. After that, I did a fellowship at Mount Sinai Hospital in New York, which was my pain management fellowship. And then I moved to the Maryland area and started a private practice and some pain centers, and continued to do some anesthesia work, but primarily pain management work.
Define for our viewers what exactly is pain management as a specialty.
So pain is, as it sounds, pain management is treatment of any sort of painful condition. It can be anywhere in the body, and it encompasses a variety of conditions that can cause the pain. A lot of our patients, of course, have things like neck pain, lower back pain. There's, unfortunately, there are some who have advanced illnesses like cancer, who develop pain, who need treatment. So at any time when the pain is unmanageable, let's say by their primary care physician, or after a few weeks, they usually come to us to look for more clear diagnosis and some potential treatment options that we can offer at that time. So I think that encompasses what we do at pain management. Yeah.
Define for our viewers what exactly then is a multidisciplinary pain center.
I think around 2 decades ago, there was really a redefining of pain. Pain is more than really a physical condition. There's a lot of mental changes, psychological changes that both may contribute to pain and may be obviously a result of having chronic pain. So what we really want to do is that in treating any individual patient, we want to take into consideration both those physical elements and those non-physical elements. So we really try to incorporate and bring in specialists who can not only, like us, who can treat specifically the pain condition from a physical sense, but also providers like psychiatrists, physiatrists, and others who can really treat all elements of the painful condition. Because what we really found is that just treating one element really doesn't result in good outcomes, and patients don't do well. And what we really want to see is people return to the things they love to do, whether it be walk, run, play sports, and certainly continue with employment if they're of that age. So that's really what's meant by multidisciplinary, just getting and looking at the pain from multiple angles.
I'm sure some of our viewers are not acquainted with the specialty of physiatry. What exactly is that?
So physiatry is really physical medicine and rehabilitation. It's a specialty that requires a residency and often fellowship training. And what it really is encompassing is looking at what are the sources of muscular or skeletal issues that may be leading to continuation of the pain. We really work in tandem. Like I said before, I'm an anesthesiologist in background, and the way that we may approach a specific condition may be slightly different from the physiatry angle. We may approach things like spinal conditions in different ways. They may look at more of the muscular components and joint components. And often they have training and different techniques that we may not be able to offer. So we try to work in tandem and get patients to physiatrists when we feel it's necessary, where we think their input would really aid in a better outcome for the patient.
As you all know, there's been an interesting evolving debate about pain management and analgesics for decades now. Decades ago, it was do whatever it takes to keep someone comfortable. And then I guess in the 1990s, there was a great deal of concern of addiction. So doctors pulled back. And then there were editorials that we were under-treating patients with pain and having them suffer needlessly. And then we swung back to do whatever it takes to get them comfortable, which leads me up, of course, to the unintended consequence of the opioid epidemic. So where do we stand at this point with treating pain? How much analgesics and other pain medicines are you comfortable providing?
I think it's variable. Certainly in certain conditions like unfortunate terminal conditions, cancer-related pain, and so forth, we tend to be pretty lenient, and we tend to use advanced opioid analgesics and so forth to a greater extent. There's really no limitation, and generally we treat the pain as is required and with as much medications as necessary. Over the last decade or so, we've tended to move towards trying to use kind of a multimodal approach. What I mean by that is, instead of just using medications like opioids, we try to use other medications in tandem that might tackle the pain from different angles. For example, there are certain medications that may be appropriate for nerve-related pains, which we can use with the opioids, or muscular pain or muscle spasms and things like that, so that overall we can really reduce the amount of all the medications, not just necessarily the opioid medications. But to really address the question that you asked, in general, for chronic non-cancer or non-terminal pain, we try to limit the amount of opioids to the lowest effective dose. We have discussions with the patients early on that that's really going to be our approach. We try to use, like I mentioned, a multimodal approach and use other medications that are non-addictive in conjunction to try to limit the addictive drug dosages. In addition, we try to, in cases where we can, utilize other sorts of modalities like interventional procedures, which may involve injection or implanted device. Obviously, those are a more difficult discussion. We need to, look into the risks and benefits of those things. But often we can use those sort of techniques in conjunction with the medications, thus limiting the amount of medications. But ultimately, we try to treat each patient individually. There may be some pain conditions that are not amenable, or they may have tried all these other modalities and they didn't work. So they may require a slightly higher dose. We really try to use the Center for Disease Control guidelines and try to limit the amount of medications people are prescribed chronically. And for those who do get higher dosages, we really try to use as many ways to assess their risk, both psychological addiction risk, as well as try to monitor them with things like urine drug screens and things like that, which is recommended by the CDC for patients above certain amounts of opioid medications or addictive medications.
When you prescribe,
that answers
you did great.
Mm-hmm.
Now, when you prescribe an opioid for pain, when do you decide that you're going to provide that as a prescription? And when do you decide it's going to be patient-controlled analgesia with a pump that they're controlling?
Generally, the patients that go on to pumps, either indwelling pumps or more sophisticated ways of delivering opioids, let's just say, whether it be intravenously or intraspine, in their spine, in their back. The real way that we start to determine the transition to that, first of all, as the dose of the oral medication goes up, if really you're not getting a response, it's like you double it, you triple it, at some point it becomes really more dangerous to use oral medications than move to another modality where you may be able to use smaller dosage through a different route. The other time that we often will use other modalities is if they have significant side effects, let's say with an oral medication. Sometimes, let's say a patient is on oral medications, sometimes if you deliver that medication, let's say in their spine, where it'll spread to all the nerves that are going throughout their body to treat their pain, you can use smaller doses and actually their side effects will go away. And when I say side effects, I mean things like nausea, vomiting, gastrointestinal effects like diarrhea, constipation, and things like that. So often those things are better when you deliver it a different way. And that's usually the way we make those sort of decisions.
How do you measure success in the treatment of pain?
So we're very careful, when we see a patient the first time, we want to know, let's say, for example, the patient comes in with back pain. There are some great instruments or questionnaire type things that we can use for patients to assess what the impact of that pain is on their life. For example, how much it affects their ability just to take care of themselves, work, do things that they like, and so forth. So we often use that as a baseline score. So, various societies, international pain societies, and others have really determined a minimum score below which functional status is pretty good. In other words, they can do all those things that they like to do. They're able to work and take care of themselves. So what really our goal is, whatever medications we prescribe, whatever interventions we do, and however we treat that specific pain condition, we want to get them as close to fully functional as possible. So there are specific scales that we can use. We always take a baseline. We periodically retest them to see what their status is. And the way we really judge their improvement is improvement there. And it kind of goes back to that opioid question or addictive medication question. If we're giving those medications and they're not really improving, then that's really a red flag for us that probably they shouldn't be on those medications. They're not helping. We're doing more harm than good. And I think that's something that in pain management has been relatively recent, is really looking at the response to the things we do and making sure we monitor them. That way, whatever we are doing, we can always show that there's a benefit to it, even though there's a risk, of course, of a procedure or a medication that we give. So outcomes improvement and measurement of outcomes is really the way we assess our success in treatment.
You'd mentioned earlier giving several different categories of medications together, and that may help potentiate things. But what are the risks, the dangers of giving more than one drug category together?
Some patients are also on anxiety medications, including and pain medications together. Pain medications like opioids tend to slow down breathing and make it more shallow. And there are other medications that are used for anxiety, things like Valium, Xanax, and others, that could also cause similar effects. When they're given together, their effects are augmented and more severe. So sometimes if a person takes both of these medications together, at a dose that leads to that decrease in breathing or slowing of breathing and shallower breathing, it can result in them having their breathing stopping or getting to a way too slow a rate, which can, of course, result in them having a cardiac arrest or something worse than that. So some precautions that we take, of course, because of this. First of all, we're always monitoring all the medications they take. We look in the prescription drug monitoring program or system, which is available in most states for controlled substances. So anytime a patient gets a refill of medications, we always look in that system and make sure that, see if they're on multiple medications can cause those sort of side effects. And then the other precaution we take is for patients on opioids, we always prescribe for them naloxone and make sure that a family member is there who can provide naloxone in case they have an overdose of their opioid medications. And naloxone is simply a medication that reverses the breathing effects of the opioid medication.
You mentioned at the top of the show that it's a multidisciplinary approach. What is the role of physician extenders like nurse practitioners and physician assistants?
Yeah, almost all pain management practices today utilize nurse practitioners, physician assistants, and so on. They're really instrumental in managing and making sure that the treatment for the patient is appropriate and safe. First of all, they help in the diagnosis, they order imaging that's necessary. They help in the ongoing management communication with other providers like psychiatrists, physiatrists, physical therapists, so forth, that are often involved. They make sure that we're always monitoring the prescription drug monitoring system and looking frequently as patients call to make sure if they're getting refills of medications that there aren't any dangerous combinations. So they really help and aid the physicians in making sure that the care for the patient is continuous and they follow through with referrals that are necessary, and really, most critically, that it's safe for the patient by making sure of all the changing dynamics that a patient, more complicated patient may have, including emergency room visits, other physician visits, and so on. So we really work in tandem with them in the care of all the patients who come through our centers.
Terrific. We're going to pause briefly for a public service announcement. More on pain management in a moment. We'll be right back.
Why would drug dealers put a lethal dose of fentanyl in drugs if they know it's so harmful?
It's cheap, it's potent, and it's profitable. Really just all about the money.
We're back. We're covering this evening pain management. Rami, my next question is, what about something more sophisticated than like spinal cord stimulation? When is that done?
So spinal cord stimulation has been around for decades, actually. It's a sophisticated modality. It's usually used for people who have spinal-related pain, which ultimately, of course, all pain can be traced back, but some specific conditions. For example, if somebody has had back surgery, and this does happen, patients have back surgery or multiple surgeries, and they continue to have, let's say, back pain, or they have what people term like sciatica, pain down their legs. And it's persistent, and things like injections and some simple medications don't work. Spinal cord stimulation can be an excellent modality that we can use. And what it really involves is tricking the nerves in the spinal cord into believing the pain is gone. So it basically is a electrical device that short circuits the system, because all our nerves are basically an electrical system. And this is an implanted device that's placed near the spinal cord in the middle of the back. that really short circuits the system and makes the person unaware of the pain. Because ultimately, we feel the pain when we sense it in our brains. So if the pain signal never is received in the brain, then the patient does not feel the pain. So it's kind of reserved for conditions where relatively simple modalities have not worked. And if surgery is indicated, surgery has not worked. There are other conditions that can be used for as well. There's a condition called complex regional pain syndrome. Sounds very complicated, but it's really a pain condition that sometimes arises when people have simple injuries, let's say in their legs, and pain just continues for months or years, and they really can't find any other cause of the pain. So it's really been a key modality and key element of treatment for those patients who really are not getting relief with simpler treatment options. And that's really what's fun. And more recently, we're using it for patients who have neuropathies, which is most commonly caused in patients who have diabetes, like insulin-dependent diabetes. Unfortunately, a lot of times with those where the diabetes is not controlled, where the sugar is not controlled on a daily basis, they may develop a stinging, burning pain in their feet, which regular medications cannot treat. So recently we've been starting to use, and the FDA has cleared spinal cord stimulation, specifically high frequency spinal cord stimulation for that specific disease.
What are your thoughts about the mechanism? Why does spinal cord stimulation relieve pain?
So a lot of studies have been done on spinal cord stimulation. So basically in the spine, the spine controls pain really all the time. There are hormones produced by the spinal cord and other areas within the central nervous system. And it's really a balance between hormones that produce pain and hormones that block pain. And really what spinal cord stimulation is doing at the spinal cord level is increasing and promoting those elements that are anti-pain, let's say, so that it is able to overcome the pro-pain element, and thus your pain is reduced. Often the pain is reduced really by almost 100% if the appropriate patient is picked and the appropriate pain condition is treated. The great thing about spinal cord stimulation as well, which I failed to mention before, was that it's not implanted right away. You actually get to trial the stimulation for 1 week. The electrical lead is just placed into the back through the skin and taped to the back, and you're able to try it at home with your normal activities for a week. So at the end of that week, what we expect for someone who goes on to get it permanently is almost 100% pain relief.
Wow.
And certainly at least 80%. So that we hold a high bar for those who actually end up getting the implant.
Now, by contrast, tell us about other options like implanted devices and surgery. When do you opt for those modalities?
Other, again, we try to go through the continuum of care. We try to approach it as simplest to more complicated. I always take that approach. So when a patient is first seen, we're really looking for, is there a simple, non-addictive, low side effect medication coupled with maybe a very non-invasive intervention, maybe an injection. Over months, if those things do not provide adequate relief or side effects intervene despite success, then we start to approach and say, is there a surgical approach? In other words, could a neurosurgeon or orthopedic spine surgeon, let's say it's a back or spine problem, is there something that they could do and intervene in? Because we certainly don't want the pain to become ongoing, because as I mentioned before, failure to treat pain can lead to other sort of psychological effects, which can then spiral into increasing pain, because as I mentioned, there is a mental component which can also augment the pain. So, and there are things at the spinal cord level where the nerves can actually cause more pain over time. So we always want to address it sequentially and make sure we're addressing it all the time. So if a surgical intervention is necessary, then we just generally refer them to neurosurgery or the type of surgeon that would be required in that specific circumstance. In cases where surgical intervention is not appropriate and other modalities have not been successful, we may proceed to things like implanted pumps that actually give medication into the spine to deliver morphine or other opioid drugs or other medications, depending on the specific condition. Those are really reserved for those real complicated cases where, things really haven't worked. Functionally, they have not improved. As I mentioned previously, we measure functional status frequently. And we really take it seriously, have a real discussion, because when you have an implanted device, the thing can malfunction, infections are possible, and so on and so forth. So we really have a discussion of the risks and benefits. But by the time a patient gets to that level, the benefits usually really outweigh the risks. And really it's that ratio that we use to base movement to a more invasive modality like that.
We'll bring up a topic that our viewers, I'm sure, are interested in. What are your thoughts about CBD products for pain relief?
So I'm in favor of folks trying different modalities. As I mentioned, we are trying to make sure that whatever we use, we're limiting each of them to safe levels. So if we're using opioids, we're trying to limit the amount of opioids. If we're using other modalities, we want to keep them safe. I believe that there's a place for CBD, cannabinoids, and others. The only issue is that I do not feel up to this time that adequate real studies have confirmed what conditions and when these type of medications are actually effective. And so it becomes very difficult for me to say a particular patient with particular issues was an appropriate candidate. So often it's really a trial and error type of scenario, which I'm okay with, as long as there's not significant side effects and the patient is not on other medications that can interact or interfere with that modality.
Thank you for a terrific interview on Housecall.
Thank you.
My thanks to Dr. Peruvemba for an excellent interview on pain management. My thanks to my team here at the studio. And finally, my thanks to you, the viewer, for welcoming us to your home. Tell us how we're doing. You can reach me at my email listed at the bottom of the screen. As for our next show, I'll be interviewing Dr. Mark Goldstein, a noted oncologist in Montgomery County, and we'll be discussing the latest assessment and treatment of colon and rectal cancer. It's going to be an important show. See you then next time for another edition of Housecall. Good evening.